So thank you all for coming. Full disclosure, I have to say to you, the talk that I'm getting ready to give to you, I've never given one like this before. And I was like, wow, this is an interesting little outside of my comfort zone. And then I thought, you know what, I'm just going to go to AI and just see what Copilot says. It actually had some really good suggestions, but then it said, oh, you've published in this area and this is the work. And I was like, oh, well, first of all, it's kind of creepy that it knew me, but so with that, I will begin. Maybe? Okay, so my topic is discussing your diagnosis with your loved ones, guidance for all generations. By disclosure, I am a consultant for Boehringer Ingelheim on a project of mental health and interstitial lung disease, and because we all know that this can impact your life. I currently have funding from the National Institute of Health, and I'm looking at a mobile application to increase access of palliative care for patients with progressive pulmonary fibrosis, and I guess I can look down here too. And then some of the images in this presentation are from an intervention I've developed called a program of support, and some are from AI. So this is an AI-generated picture. I was like, could you make us a pretty flower that conveys some hope? Maybe we'll move forward. Maybe I have to. There we go. So today, sharing your diagnosis. These are the 3 points. One is understanding the emotional landscape. It is a very challenging time in your lives. And then preparing for the conversation to share your diagnosis, and then navigating reactions and building support. So the first point, understanding the emotional landscape. So you all know this better than I do, or any of us know, that when you receive a serious illness diagnosis, everything in your world kind of stops. And the first thing you're wondering is, why me? And what does this mean? What does the road ahead look like? And not only is it trigger emotions for you, but it triggers emotions for those that are close to you, your loved ones, your family, your friends. And it's really important to recognize that everyone will have a different response to your news. And you think about it in your daily life and your network of people and how people respond to other news. So it's very common that people will respond differently to you. So just to be prepared for that. So patients and caregivers, it's really important that you listen to your body and you acknowledge your emotional needs. And this is a time to give yourself grace and understand that there's a lot of fear of the unknown. And when you surround yourself with a good care team, that this will help you, navigate the journey ahead. So preparing to talk about your diagnosis. So it's really important, like, how do you do this? And so I guess I have to, okay, reflect. It's really important to sit down, reflect, and take some time to recognize your own feelings. And then select a setting that is safe and it ensures a safe conversation. So this is somewhere that it's important that you feel that when you're having this conversation that everyone feels safe. And then if you're afraid that you're not going to remember key points, it's okay to write down and take notes and to have those so that you can, refer back to that to help you. So preparing your conversation, reflect first. What are your hopes? What are your fears? What are your expectations? And then remember, you're in the driver's seat, so you get to decide when, where, who, and what you want to share. And you want to use clear language to avoid confusion. This is not the time to use medical jargon that we frequently use in the medical field. And I will give you an example. When I did my dissertation study, one of the patients shared with me that when he got the diagnosis of idiopathic pulmonary fibrosis, he wasn't sure exactly what that meant. And he was hesitant to ask the physician because he didn't want to come across like, I don't know what this is. And then for those of us in the medical field, we've heard the patient come back and say, well, I was told I had interstitial lung disease, I had interstitial pulmonary fibrosis, I have usual interstitial pneumonia, and no one had told me that all they had to say is, you have unknown lung scarring. And because of that unknown lung scarring, it's impacting your ability to breathe. And when I did my dissertation, I had this slide that had idiopathic pulmonary fibrosis equals unknown lung scarring. And this patient, one of the participants, said, he was a retired engineer, and he said, oh, well, no one ever said it to me like that. Now I totally get it. So we have to speak language that people can understand and appreciate. And so alternatives. If you don't feel comfortable talking about it, you can write a letter. And this is something we often suggest to people alongside during the journey of their disease, is that, say, for example, you want to attend your grandchild's high school graduation, and they're in kindergarten. And so we are hoping that you can do that, but in the event that you can't, you write a letter to them of your thoughts for this particular grandchild. That is a really nice way for you to, it's catharsis in a way, but it's also a gift to that grandchild. Now, you need to be prepared to navigate reactions and build support. And as I mentioned before, loved ones may react differently. Some may have hysteria, some may walk away, and you may feel that you're abandoned. And so it's really important that you prepare yourself to think, well, how will people respond to me? And you need to allow space for emotions. And then being prepared for these very varied responses, these can help strengthen relationships with all these individuals. Because going down the road in this journey, as many of you know, you're going to need a lot of support. And so you need people to be able and ready to support for you. Now, something that's really important, though, is you need to set boundaries. So, you know, I come from Pittsburgh, big Steeler town, football town. I hope you all are Steeler fans. But I always like to use the analogy, you are the quarterback of your team. So you're the one that is driving the bus. You get to set the pace. So you have the right to control the conversation. Setting boundaries during conversations, it's vital to protect you and your emotional well-being. And it's not something that you should ever feel guilty about or think, well, I don't want them to think this, that, or whatever. This is the time that you think about you. And then clear limits help you to maintain control. So, building your support network. So, sharing your diagnosis with others invites emotional and practical help. So one of the other patients in my study said to me, you know, when I went home, everybody in my community was like, we've watched you, we know you've been having shortness of breath, nobody knew what was going, so you went to the city, to the university, to be seen by a specialist. And the patient reported, he said, when I came back, all my community was like, well, what did they say to you? What was it? And the patient said, well, I don't remember all the words. There were a lot of letters. But they said something that had fibrosis in it. And he said, my friends were like, but wait, fibrosis, that's cystic fibrosis. That's what happens to, isn't that kids? I'm like, you're not exactly a child. And so it's that, you know, being able to share this with this group of individuals because they want to help you. I'm sure if you've attended some of the other sessions today, people want to help may not always know how to help, but they want to help. So it's important you get to tell them your narrative of what you want. And then it's important to realize that support is vital throughout the journey. It's really important to have everyone that you want on your team. And this can go from family, friends, or others going through the same serious illness. And so this brings up utilizing resources that are available to you. It is really important, and I will state my bias up front. I ran a support group for 20 years, and I saw the benefits that patients and caregivers receive from attending a support group. When you attend a support group, you meet others who are going through the same thing at the same time. And to watch the interactions from face-to-face interactions and now virtual interactions, and there's so many more support groups that are available now for you to attend, and it's really important when you attend these support groups, you hear from others going through the same things, they share your stories, they may have some tips for you, you may have some tips for them, but you're in this mutual journey together. And I can't underscore this next one enough. Get your information from factual sources. We would have patients come to us in clinic, and people mean well, but they would say, look, I saw in the newspaper that there's now this new stem cell therapy that you could get, or you could buy these special vitamins, and you should ask your doctor about it. So they'd come in with their newspaper clipping, and the doctor would say, no, provide factual information. So I can't underscore that enough. Get your information, and I'll put a plug in for the PFF. If you haven't been on their website has amazing resources. And then the other thing about attending this support group is it not only helps you, but you get to give back and you get to help others on this journey. So final thoughts in this presentation. Take your time and set boundaries during your discussions about your health. Remember that you are the one driving the bus, and you get to share what, who, when, and what you want to share with your community. Sharing a diagnosis often opens the doors to empathy, and it supports and fosters meaningful relations. And then lastly, strong relationships and support networks help you to navigate this career. As you can see when you look around, that there are many people that are on supplemental oxygen. And as your oxygen needs increase, if they do, it's really, you're gonna need other people to help you when you go to your appointments, if you wanna go out and about to navigate with the oxygen. So hopefully this is helpful, and then questions will be at the end. So thank you.
Great, thank you very much indeed, Kathleen. I talk to recently diagnosed patients every week, and I think what you've said today is going to be very helpful to me in future, so thank you very much for that. It's now my great pleasure to invite Dr. Bridget Collins to talk to us. Bridget is Associate Professor at the University of Washington and specializes in diagnosis and management of patients living with ILD. She's published extensively and has been principal investigator for a number of clinical trials focused on pulmonary fibrosis. She enjoys teaching, so you'll enjoy talking to us this afternoon, and teaching patients, medical students, residents, fellows, both in the clinic and in more formal settings. So, Bridget, over to you. I look forward to your talk on living with ILD, strategies for balancing home, work, and health. Thank you.
Thank you. Okay. So I'm going to talk today about strategies for balancing home, work, and health while living with ILD. And this, like Kathy said, is also a different type of talk for me than I've usually done. So I'm going to do my best to go through it. I have no disclosures. I do want to make a little disclaimer that everybody's unique and everybody's life is different. The goal of this talk is to really just share strategies that I've observed to be helpful and patients have observed to be helpful. I spend most of my time in the clinic as an ILD clinician, so for the past 10 years, I've been very fortunate to get to work with many patients with ILD and share their journey with them. My objectives today, one is to describe what is balance. Two is to discuss what's been shown to improve health-related quality of life with ILD, and then I'm going to share some themes from a survey of patients. So what is balance? There are so many books and podcasts and things written about life balance, but what does that mean? These were a couple of definitions that I liked. One is it's about equal worth, so giving your values, health, relationships, and your peace the right to exist as your goals. From this book called The Balance Equation, they noted balance comes down to how you spend your time, who you spend it with, and where and when you spend it. And they have this little cycle of kind of assessing where you are in your life, how you're spending your time and energy, reflecting on where you would like things to be different, kind of prioritizing what you want to change, and then kind of making micro moves, growing and going through the cycle again. This is just a pie chart of what balance could look like for 6 different patients, because balance is going to be different for everybody. So health, home, work, relationships, leisure, service, we all have a different pie chart in our life. And then it changes over time. So as we're going through life, we're all evolving, and things that are most important kind of fluctuate. This is just from a survey, the Global Burden of Disease survey in 2019 that looked at patients with ILD living in the US. And I showed this mainly to highlight that it was about half male, half female. The age, so, oops, wrong way. Maybe we'll go back. There we go. So per 100,000 people, there were about 52 people who were 15 to 49, 375 who are 50 to 74, and then 976 who are over 75. And this varied a little bit by state. But I show it just to show that there's people living with ILD kind of across, entire different areas of life and across the lifespan who are balancing different things. This is a quote from my friend and medical school classmate, Paul Kalanithi, who wrote When Breath Becomes Air. Paul was diagnosed with metastatic lung cancer when he was finishing his neurosurgical residency and wrote this book about kind of going through the process of illness and treatment, and it was published after his death. But he noted that the tricky part of illness is that as you go through it, your values are constantly changing. You try to figure out what matters, and then you keep figuring it out. So I show this just to show that we're kind of always evolving, things are always changing, and that's to be expected. Thinking about data, like what data do I have about balancing things in life? There's not really studies out there. The closest I can come is looking at health-related quality of life. So health-related quality of life is your satisfaction or happiness with your physical, emotional, and social well-being as affected by your health. Many of you have likely done clinical trials where there's now often patient-reported outcome measure tools, which are questionnaires where they ask you about how you're functioning, how you're feeling, your symptoms, how you're doing socially. The one thing across the board that's really been shown to improve health-related quality of life in people with a variety of interstitial lung disease is pulmonary rehab. Which pulmonary rehab, you go usually for 12 weeks, and it's twice a week, and you do exercising that's supervised, monitored. There's typically an education component. And it's the one thing that's been shown consistently to improve quality of life and shortness of breath. Those who have more severe disease and exercise impairment actually benefit the most, so even if you're quite limited, you can still benefit from pulmonary rehab. I tell my patients that it's okay to increase their oxygen flow if directed to do so to increase their activity level. I have quite a few people who worry that they'll get addicted to their oxygen if they use it. And we talk about the fact that if you're needing more oxygen, it's because your disease is changing or something else is going on. And I'd rather have folks be active in using more oxygen. We do know if you don't keep up with an exercise regimen after pulmonary rehab, you lose the benefits by like 6 to 9 months. Some programs will have an extension where you can keep going once or twice a week. I've had other programs where they'll help the individual make like an exercise plan so they can keep it up at home. So it's kind of important to keep going. And if you don't live in an area where pulmonary rehab is available, there are virtual resources. The PFF has a pulmonary rehab toolkit, and then the Canadian Lung Association also has some virtual information. Other things that have been studied, breathing exercises. Our group did a small study looking at chair yoga in people with IPF and found a small quality of life benefit. Recently, there was an interesting study looking at digital cognitive behavioral therapy. So it was developed by ILD experts and CBT experts, and you do it on an app or a smartphone, and it's modules that you do over 9 weeks. And it's for people who had pulmonary fibrosis and anxiety, which is a significant amount of people with ILD, but I would argue it's a significant amount of the population overall has anxiety. And they found that after 9 weeks, it improved health-related quality of life and anxiety. So we may see more digital tools that people can access in their homes. And then there have been variable results with disease management programs, particular medications. There's not one medication that's been shown to consistently improve quality of life. So I'm going to spend the last few minutes just sharing some themes from a small patient survey. I sent some questions out to the Pulmonary Fibrosis Support Group at University of Washington, and then also discussed with the Women and Interstitial Lung Disease Support Group, because I wanted to get input from people who actually have interstitial lung disease to share strategies that they have found helpful. And throughout this, I'll pepper some of my little thoughts as well. Across all the domains, so work, home, health, there were some common themes that came out. One is support and connection. So finding people who you can talk to about your disease, who you can call on. Kathy talked about support groups, and one of the things that came up is finding the right support group, so the support group that kind of works for you. Education and taking an active role in your disease was mentioned. Sometimes it feels like there's not much you can control, but you can control kind of what you learn about your disease and how you deal with it. Gratitude for the present, so things that you can do currently. Self-compassion, giving yourself grace, which is hard for a lot of us to do. And then preparation came up as well, and this came up in a couple ways. One was kind of thinking about planning ahead. So if you're going to be moving homes, thinking about, do you want a one-story home or a home with a lot of stairs? Traveling, so thinking about traveling and oxygen. People mentioned getting their affairs in order. So estate planning, having a will, gave some people a sense of comfort that things would be taken care of. And then organization came up as well. So keeping a schedule of appointments and things you need to do helped people kind of stay on track even when they weren't feeling well. Activity was something that multiple patients mentioned. So pulmonary rehab, staying active with exercise. And then at the end, I asked people, is there anything else you think would be helpful for me to know? And multiple people wrote back and said they wish they had used their oxygen sooner because they found that they were able to do more when they used it. And so I'm going to pass that on because it was a pretty clear message. I'm going to go into each of these a little bit more, starting with home, so ways to kind of balance life at home. One is accepting help, and sometimes things are good enough. Sometimes it's okay to have takeout for dinner instead of cooking a meal. Talking to your family and friends and caretakers about what ILD is. Most people have never heard of interstitial lung disease, and so talking to them about what it is and how it affects you. And the PFF actually has a nice card that you can give to friends and family with some kind of basic information about ILD that can help with that conversation. Determining what's most important for you to do. I talk about this a good amount with patients. So if, for instance, you're having your friends over to play board games, kind of use your energy on that instead of making sure that your kitchen is spotless. So kind of targeting your energy. I mean, we could all learn from that. I could learn from that as well. And then identifying and engaging in activities that you enjoy to kind of give you a mental break. So things that came up, reading, theater, walking, you name it. And then again, this organization routine. And doing this, I felt I should be a more organized person by the end of it because it kept coming up. At work, noting that health comes first, being honest with yourself about how your disease might affect your ability to work and also how you feel about work. Sometimes the way we feel about our career changes when we have a serious illness. Sharing as much or as little as you want to about your condition, it's really up to you. Again, routine being helpful. So if you're, every day getting up, getting ready, making your lunch, feeding your dog, going to work, having that routine in place helped people so when they were feeling poorly, they could still kind of make sure everything got done and stay on track. And then preparing for potential sick leave. So I mean this both mentally, like telling yourself you might have to take some time, and then also knowing what the policies and the process are where you work, so when it does come up, you're prepared. In terms of health, prioritize your health. Multiple patients brought up mental health and kind of accessing therapy if you have the resources to do so. Keeping up with other medical conditions, so things like sleep apnea or anemia, low blood counts can make people feel fatigued, and that can kind of contribute to the overall picture. So keeping up with those conditions as well. Protecting yourself, so vaccines, telling folks, if someone's gonna come over, if they're sick, maybe tell them not to come or come another day. Try to protect yourself from infection if you're immunosuppressed. Exercise, and I put here walking counts because I think a lot of us feel like we have to do 50 minutes of cardio 5 times a week and lift weights, and like that's what counts as exercise. But even just taking kind of multiple short walks throughout the day can be helpful. And then, of course, pulmonary rehab, as I mentioned. Sleep. So people with interstitial lung disease are more apt to have sleep-disordered breathing, things like sleep apnea, but also have been shown to have poorer quality of sleep. And sometimes that's because of symptoms like cough, but it's also just overall. And so if you're having, waking up not feeling refreshed, snoring, people are saying you pause in your breathing at night, could be a good idea to get a sleep study to see if you have sleep apnea. Also, what's called sleep hygiene. So, going to bed at the same time every day, waking up at the same time every day, having a dark, quiet room, no electronics, making sure you get enough sleep so the sleep you do get is as good quality as possible. In the nutrition, this could be, any of these could be their own talk, and I think there is a nutrition talk going on right now. But what I wanted to say is there's not one specific diet that's recommended for everybody with interstitial lung disease. Looking at the literature, one of the things that often comes up is maintaining your protein intake, because we know that over time, as people lose muscle mass, that can be associated with worse outcomes. And then it's going to be individual. So some people have acid reflux and have to do a diet that helps with that. One thing I talk about with folks is sometimes my patients feel like because they're not as active as they had been, that they don't need to eat, or they shouldn't be eating. But when you're sick, especially if you're in more advanced stages of your disease, your body is working really hard just to kind of do your regular activities. And so it's important to keep up with eating and nourishment. Often smaller, more frequent meals can be helpful, because when you eat a big meal, it fills your stomach and it can kind of press up on your lungs and make breathing harder. These are just a couple of resources that I thought are helpful. The first is a pulmonary support group finder. So this is through the PFF website. One of the positives that came out of the pandemic is there are a lot more virtual support groups now. There's also a pulmonary rehab toolkit. The American Lung Association and Action for Pulmonary Fibrosis have some great things on their website. And then PF Warriors had a nice section on travel and thinking about traveling with oxygen. And then also some tips on kind of mental health and anxiety. And so I want to thank the University of Washington Pulmonary Fibrosis Support Group, and then also the Young and Wild Women with ILD Support Group, who helped me out as well with this. That's it.
Great, thank you very much, Bridget, and also for the Action for Pulmonary Fibrosis publicity at the end there. It's really important, isn't it? Good, clear information that you can rely on at the time of diagnosis and through the journey. Fantastic. So onwards then now, it's a great pleasure now to invite Professor Kristin Hyland to join us. She's Professor of Medicine at Cleveland Clinic, Lerner College of Medicine at Case Western Reserve University, where she's also the Vice Chair of the Integrated Hospital Care Institute. Her clinical research interests focus on rheumatic lung disease, with an emphasis on ILD and pulmonary hypertension. She's a scientific advisor to the Pulmonary Hypertension Association and to the Scleroderma Foundation. She gave a really nice, interesting presentation this morning in the clinical trial innovation session before lunch on Decipher ILD, a new program for, a registry program for PH-ILD over 5 years, because we really don't know how it affects us and how it, over time, and it's going to be looked at in great detail. So look forward to hearing from you, Kristen, on Beyond the Diagnosis, Relationships, and Family Planning. Thank you.
Thank you, and it's really my honor to be here. I love talking to patients, and I congratulate you for coming to the Pulmonary Fibrosis Foundation meeting, because there is so much more to living with interstitial lung disease besides seeing your doctor and getting prescribed medicines and measuring your forced vital capacity. That's a tiny part of your journey. And it's so important that it's not defining you. So that's what we're going to talk about. So I learned this lesson about 15 years ago when I saw one of my most favorite patients. He was 40. He was a triathlete. He had a young wife. They were thinking about having a family. And he got ILD that was rapidly progressive. He needed a lung transplant. And he's done well. He's still alive. But, he really affected me. And every time, I would see him, his lung function would be a little bit worse, and I just could hardly stand it. And we got talking about his journey after he had his lung transplant. And to my surprise, he said, if I could change anything, I wouldn't. This has made me a better man. I'm a better husband. I'm a better son. I'm closer to God. And I appreciate every day that I have on this earth. He's like, this is the silver lining. This is what dealing with this disease gave me. He had post-traumatic growth. I'm not going to deny how awful interstitial lung disease is and to survive it. But what I'm going to wish upon you is your silver lining. That you will find the benefit, the silver lining of what you're having to go through. That is what I'm wishing. You are more than your disease. And this interstitial lung disease may change how you're living your life, but it is not who you are. It's just something you're dealing with, and we're all dealing with stuff. And you will grieve your losses, but you will rebuild around things that still bring meaning to your life. And we're going to talk about how relationships and emotions and family planning at whatever stage is affected, and how you think about that as you think about your future. So it's important to think about the whole person. Shortness of breath, fatigue, medications are more than the physical. Emotional and relational health is part of your treatment. Education, social, cultural, spiritual. How is this affecting you financially? How can you function as a parent, or relationships with your partners or your parents or your friends? How does this affect your work or occupation? You know, the medical treatment also includes how you're doing emotionally. That can play a big factor in your disease. Now, you've heard a little bit already about, there's an emotional journey, and I'd like to emphasize the word living with, as opposed to dying from or living under, but living with interstitial lung disease. At first, I imagine that there's a lot of shock and uncertainty. What does this mean for my future? I'm sure you've Googled IPF. Dr. Google's pretty scary. Don't consult Dr. Google. Very mean guy. How is this gonna, there's gonna be fear and loss. How does this affect my work, my independence? And then you're gonna be able to adapt. You're gonna figure it out. You're gonna find new routines. You're gonna find sources of joy. One of the things I tell my patients to schedule 1 hour of something every day. And if you can't do 1 hour, schedule 15 minutes of something that brings you joy. Doing the crossword puzzle, doing a bubble bath, calling your best friend, petting your dog, scratching your cat behind the ear, something that brings you joy. And sometimes you have to purposely do that when you think life is a disaster. Spend a little bit finding that joy. And then you will get to acceptance and hope. And you will reconnect with purpose. And you will redefine your goals. But this is going to feel like an earthquake. But you will learn to live with interstitial lung disease. And you need to keep in mind, what's happening? Oh, I forgot that I had a build. I want to emphasize the power of hope. Hope is not denial. It's the ability to look forward even with uncertainty. And I also want to emphasize what our last speaker said, was that therapy, emotional therapy, that's not a sign of weakness. That's brave to confront things face on and get those things in your toolkit so that you can go down this journey with some strength. Pulmonary rehab, so important. Mindfulness and this peer support group. So let's not forget the caregiver. They're going on the same journey with you. Caregiver, caring, they're always there, they're ready to give their all, they are encouraging, they're gracious, they're incredible, they're valuable, they're exceptional, they're respectable. And when you get your diagnosis, they're also feeling fear and helplessness. They're watching someone that they love struggle. That is tough. And they don't want to show it because they know you're struggling as well. And they're trying to figure out how to balance their life and their work and their self-care. And caregivers get burnt out. So then they're dealing with resentment, and then they're resenting the resentful of the resentment. They feel bad. But then they learn to adapt, and they love differently, but they love. And so we have to remember that caregivers experience their own version of this illness emotionally and physically, and caregivers need care too. So it's important to address the elephant in the room. if you don't, this is what's going to end up, okay? This is not a connection. This is ignoring the elephant in the room. And I can tell you, I have experienced this unwillingness to communicate in my personal life. My dad had a chronic illness, and I knew about his illness for 2 years before he was willing to confide in me. So I had to keep it a secret that I knew about it. And I knew how much my mom was suffering, and she wasn't allowed to talk about it. And that caused harm. That unwillingness to communicate caused harm. As hard as communication is, it is so important. Open and honest communication strengthens relationships. It builds connection. That vulnerability is a part of intimacy. It is important for relationships. So share your feelings. Don't protect. You are not protecting your loved ones by being silent. And invite conversations. Because people don't know, they're afraid of saying the wrong thing, or they don't know what to say. So invite conversation. If you need to, consider counseling, couples counseling, so that you are in a safe space to communicate your needs. And you need to discuss boundaries. We already heard about boundaries today. I so often see patients and the spouse is hovering like a helicopter and it's making the patient absolutely bananas. And two things are true at the same time. The patient wants some independence, and the caregiver loves and wants to help and discover boundaries. What can I do? Where do I need help? So listen openly and plan together. Love and connection adapt. They don't disappear. Let others help. It strengthens, not weakens, relationships. So intimacy is about closeness, trust, communication, and connection. It is more than sex. We all like sex, right? But it's more than sex. It is a spectrum of emotional, physical, spiritual, and intellectual bonds. There's a lot that goes into intimacy. This is your opportunity to become more intimate, because intimacy changes but doesn't disappear. After an interstitial lung disease diagnosis, I would argue you can become more intimate because of this diagnosis. And oxygen and fatigue and medical devices may change how intimacy looks, but not what intimacy means. Intimacy is a feeling of being known and valued and loved no matter what changes, and that requires oxygen. But you can have a healthy sex life with interstitial lung disease. It's part of your well-being, and it's okay to talk to your provider about it. Most of us will go, oh, but have that conversation anyway, okay? Because it's okay. So plan around time when you have the most energy. Try new positions, like maybe side to side, lots of pillows, things that can reduce breathlessness. Focus on connection, encourage conversations. It's not necessarily about performing, but it's that closeness that matters. And wear your oxygen. Sex is exercise. Oxygen helps. So does pulmonary rehab. Go to pulmonary rehab so you can have sex, okay? All right. Intimacy doesn't end with illness. It evolves with understanding. And give yourself some grace about body image and confidence. Be compassionate towards yourself and talk to your partner, because vulnerability invites closeness. Now, with family planning, it's never too early to talk about family planning if you're in the age range where, you know, you want to have a baby. Thank God that's over. But careful planning is essential. And that involves shared decision-making with you and your partner, your pulmonologist, and OBGYN. The impact of interstitial lung disease can affect pregnancy, and it depends on the type and severity of your disease, your lung function, medications, and so you need a high-risk obstetrician. If you're male, you may need to think about things like sperm banking. And if you're female, you may want to preserve your eggs, or the two of you may think about adoption. But pregnancy is exercise too. So your need for oxygen goes up. You may need to wear oxygen while you're pregnant. It's a lot of work to be pregnant for those 9 months. So I will kind of be finishing up that parenting and grandparenting with interstitial lung disease, kids also benefit from age-appropriate honesty. Mommy's lungs are tired. Be present. Prioritize time and activities that matter the most. Your kitchen doesn't need to be spotless, okay? Choose activities that fit your energy. Accept help from family and friends because it models strength, not weakness. It's going to teach your kids and grandkids about resilience. Focus on presence and not perfection. Chronic illness changes parenting, but can deepen bonds. And remember your care team. You are not alone. Your team is your partner. Your ILD care team has pulmonologists and nurses and pharmacists and social workers and other specialists. And have that conversation with them about your mental health, about the need for pulmonary rehab, about genetic counseling. You heard about that earlier today. Support groups, palliative care, which improves your quality of life at any stage. Hope and planning can coexist. Advanced directives and life goals, reduce stress later, celebrate those milestones, graduations, anniversaries, and travel, because you can live a meaningful, connected, loving life, even with interstitial lung disease. Starts with understanding, openness, and hope, one breath and one relationship at a time. Thank you.
Thank you very much, Kristen. There was so much in there that I think we'll come back to afterwards. Thank you. Now my pleasure to invite Dr. Erica Ferran to come to talk to us. Erica is Associate Professor of Medicine at the University of California in San Francisco. She probably wishes she was in the Californian weather at the moment instead of here. She's a physician scientist whose research focus is on improving the delivery of evidence-based, patient-centered care for individuals living with ILD. She's an active member of the PFF and is deeply committed to mentorship, interdisciplinary collaboration, and advanced advocacy, health equity within the ILD community. Erica is going to talk to us about representation matters, engaging diverse representation in ILD research. So over to you, Erica. Thank you.
All right, well, thank you for hanging in there with me. This is the last talk of the day, so I have my work cut out for me, just timing and after following these very thoughtful and reflective talks. We're going to switch gears a little bit here and end with a bit of a call to action about the role of research. And this feels like a very safe space to have this conversation because the PFF has been an early leader in this space, recognizing that we are better in the care that we deliver, in the education that we deliver, and in the science that we produce if we bring everybody to the table, all stakeholders. If it's scientists doing research and publishing that research and discussing that research amongst themselves, then we're not actually moving the needle forward in the care that's delivered. We need to have that conversation by bringing together patients, clinicians, scientists, industry, caregivers, all together so that there's that crosstalk that really enriches the science that we produce and the care we produce and the education. And so PFF has been an early adopter. This summit is sort of a pinnacle of that work and engagement and effort they put forward. And I'm going to focus a little bit on what that means for research, for all of us, particularly for patients. I'm going to start with, there was a report that came out from the National Academies of Science, Engineering, and Medicine 3 years ago that talked about just generally, what is the impact of ignoring equity when we talk about research? And there's moral and ethical reasons why we need to think about inequities in research, and I think those we can kind of grasp. But there's also a scientific and financial and pragmatic cost when we don't think about that. The costs of research go up, our return on investment goes down when we don't generate research that applies to broad populations. Our ability to innovate really relies on ability to identify populations that might behave differently. And we can't identify those populations if we're going to the same groups of people over and over again to get them engaged in research. Our ability to recruit to trials effectively and reach our endpoints and study our endpoints relies on reaching broadly, casting a broad net. And then from a moral and ethical standpoint, trust with patients, with communities, our ability to address disparities as opposed to worsen disparities with our research, all depends on our ability to really engage all patients or have all patients the option to engage in clinical research. So now let's talk about ILD and who is missing, okay? That's the first question. So to answer this question, I turned first to the Pulmonary Fibrosis Foundation. And I asked who's missing in our PFF registry. And a lot of these gaps, they're well known, but I just want to identify them, sort of like speak to the elephant in the room. First is geography, right? The PFF has done a lot to expand the Pulmonary Fibrosis Care Center network and who has access, but we can see even with that, there are broad swaths of the country where there is no care center network. And that means those patients are not represented in one of the major engines for research and understanding pulmonary fibrosis. There's also a skew in the diagnoses that are there. So we know that IPF is about 25 to 30% of all ILDs, and yet in the IPF registry, it's about 60% of the patients. Now that was intentional when the registry was designed, but it is a challenge when we're trying to understand the full scope of ILD in the country. Beyond the PFF registry, there are other national registries that look at IPF and ILD, so IPF Pro is one of those. And here I'm going to talk a little bit about racial and ethnic demographics. So on the left-hand side, this is a chart of census data, the most recent census data. And on the right, you can see the makeup of the race and ethnicity makeup in IPF Pro. Now, we know that there are racial and ethnic and gender and age differences in who gets IPF, right? And yet, that doesn't explain that full difference. There are other reasons at play. Who gets diagnosed? Who gets to a center that does research? Who gets asked if they want to participate in a registry? And for us to really understand the racial and ethnic makeup or demographic makeup in general of a disease, we have to address those other issues that impact who gets to participate in research, right? When we look at ILD, so ILD, casting a broader net, we think we're going to probably get a more racially and ethnically diverse population, and we see that. We see more non-white participants, but it's still quite skewed. And so we recognize that we're still having that Swiss cheese model when we look at IPF or when we look more broadly at interstitial lung disease. And then we look at clinical trials. So we have a drop-off from the census population to registries, and then we have an even bigger drop-off when we look at who gets into clinical trials. So we look across clinical trials, about 14% of clinical trials are made up of non-white participants, and only 22% are made up of women, right? And so when we look at the trials, making sure that every patient is represented in those trials so that when clinicians or researchers are looking at that information trying to understand if it applies to their patient, it means their patient needs to be represented in who was involved in those clinical trials. And this tells us we have some work to do. My group wanted to understand, well, are we getting better at that? And to understand if we're getting better at it, we have to know if we're reporting that information, right? We have to be transparent in sharing that with each other. In 2017, there was a federal mandate that we had to report to clinical trials demographics. So it's not enough to say, I tried to enroll all patients who have this disease, but I have to tell you how good I was at doing that, right? And what you can see in 2017, all of a sudden we became very good at reporting sex and gender. 100% of studies now report that. We're lagging in race and ethnicity. And so as we start to think about how to recruit more diverse patient populations, we're not going to know if we're making a difference if we're not sharing that information with each other. Okay, so I've showed you, I think, pretty definitively that there is a gap in who's participating in research. And now the question is, why does that matter, right? Okay. Well, the first question is, like, does it matter from a treatment standpoint for how effective or safe medications are? And the top line here is there is not clear data that there are biologic differences in how medications impact patients by race, ethnicity, by gender, or by age, okay? And so that tells us that we should be thinking about prescribing antifibrotics and immunosuppressants to all patients for whom we think there is a clinical benefit. Where there is data that there's variability by demographic is when we think about pharmacokinetics and safety. So if you're older, I need to be more concerned about infections if I'm prescribing immunosuppression. If your body size is smaller, or if you're of a certain race or ethnicity, you may be more prone to certain side effects from medications. And so it changes how I monitor you or how I may dose a medication, but it should not change whether I offer that medication to you, okay? However, to answer that question definitively, we really have to have enough participants from all of those groups in our clinical trials to be able to test it. So the data right now tells us there's no difference, but that data is also based on populations that are not representative of all groups, right? And so we have a little bit of a mismatch between the data and being able to definitively answer. Where we do see big differences is in access, uptake, and outcomes. And here I just want to clarify, because it's a little bit confusing. The green check seems to think we're doing well. No, that's where there is data to suggest there's a problem, and the X or question mark is, the question mark is telling you the data is sort of mixed. But I want you to just see how many green checks there are. And that tells us that we have a problem. Antifibrotic use, clinical trial enrollment, lung transplant, ILD access and care, there are significant differences by race and ethnicity in all of those categories. Same with gender, geography, socioeconomic status. So while the medications may be equally effective, who gets those medications and what happens to them is very, very different. And I'm going to just give you some examples of that. So this is a study that came out of the group in Chicago, which looked at the disease trajectory in IPF. And I apologize, I know this is an ILD discussion. Most of the data here is in IPF. So the examples I'm going to give are in IPF. But we see similar themes in other ILDs. So this was looking at the disease course in IPF. And what we found was that when you looked at Black patients with IPF, the entire disease course was moved up a decade. When they were diagnosed, when they were hospitalized, if they got transplanted, and when they died. And so if we're giving illness scripts to our clinicians and telling them you should start screening for IPF in your late 60s, early 70s, that's who gets it, well, that's too late for an entire group of people. We've missed the boat. Treatment varies in IPF by gender and income. If you're a man, your odds of taking an antifibrotic are significantly higher than if you're a woman. And yet the medications are equally effective in genders. So what's going on there, right? Same thing with income. If we look at patients who have make $200,000 or more, that's the comparative group. Every income bracket compared to that has a lot less likelihood of taking the medications. Okay, so this is just reflective of the real-world implications of not including all people in our registry studies, because the treatment is, their experiences are very different, and in order to move the needle forward, we need to capture those experiences. And the last one I'm giving you is IPF severity by geography. So this is a study looking at patients who live in rural areas versus suburban or urban areas. And what they saw was that survival in the first year, year and a half was significantly worse for patients who were coming from rural areas. And when they then controlled by how severe the disease was, that went away. And so that tells us that it's not that those patients do worse overall because they live in rural areas. They do worse because by the time they get to a physician, they are much more advanced. And so how we reach out to patients in rural areas needs to look very different than how we reach out to patients in suburban or urban areas. And yet we know from our map that a lot of those rural areas are not included in our registries. Okay, so then what do we do, right? I think I've laid out a pretty sort of sobering landscape of where we are. How do we build more inclusive ILD research? The beauty is there's a lot of work that's been done here and there are clear steps, so let's go through them. The first is to start by conferences like this, where we don't just talk to each other as researchers, but we kind of think about it from everybody that's involved, and we intervene at each of those levels. So at a patient level, we need to think about transportation, incentives, flexibility in how you can participate in research, thinking about cultural and language differences and how we're approachable for all individuals. For clinicians who are talking about clinical research, it's making sure that you're talking about it with all patients that come through. You're giving the patient the opportunity to learn about it and decide, as opposed to making maybe a decision about whether you think research would be a good thing for that patient. And that requires building trust with each other and with our community partners. At an institution level, it means diversifying research teams and aligning clinical and research priorities. So this was a big thing that I think came out of the PFF and patient engagement, which is we were doing a lot of research discovery about medications, and patients were saying, I am coughing. None of these medications make me feel better. What are you going to do about cough, right? And it was listening and hearing that and bringing that into the conversation that helped to think about PROs and investing in studies that are going to look at cough. And then at the federal level, it's thinking about funding studies or incentivizing studies that are actively engaging with community partnerships, actively engaging in inclusive research. At a trial design setup, there's a number of interventions, and just to highlight a few, it's decentralized trials, so allowing people to participate from clinical trials from their home using things like home monitoring. It's using a standardized framework for presenting clinical trials to all patients, so we remove the bias piece. And then it's thinking about sort of pragmatic trials that can happen within the context of clinical care, so there's less of a burden, because actually participating in a clinical trial, I don't know how many people have before. I did it during COVID just to understand what that process was like, and it's a lot of work, right? And so if it's not integrated into clinical care, it's really hard to ask someone to do. The good news is it's happening. And so I wanted to highlight the PFF registry, the community registry. This is sort of just phenomenal that it is available. This allows any patient anywhere in the country, go to this website, and you fill out surveys about what your experience is like. No longer do you need to see a clinician to be referred. No longer does your provider need to collect that information. This registry is going directly to patients. So please go to the website if you haven't participated and learn about it. Registries like this will allow us to better capture who is affected by ILD and what their experiences are. Using remote monitoring devices, there's a lot of work in home monitoring happening, and integrating that into clinical research will allow people, again, to participate in research from their homes. And then lastly, AI and machine learning. I'd be amiss if I didn't mention this, talking about how we can use big data and large data sets to better understand the disease and capture patients irrespective of who they're seeing in clinic and who's referring them to a trial. And I'll end with this, which is that representation builds trust, and trust builds better science. No one party in this can do it alone. Each patient, for patients, understanding that your experience is data that we can learn from. clinicians recognizing who you talk about clinical trials with, who do you refer to clinical trials, has a big impact on the success and meaningfulness of those trials. And researchers in industry recognizing how we design trials really impacts who can participate in them. And so needing to be intentional about the design. And I'll end with that. Thank you.
Well, thank you for leaving us with so much energy, Erica. That was great. Okay, well, the agreement was the first, I said 5, let's say 3. 3 questions have to be from a patient or carer. Would anybody like to start? Anybody at all? If not, I qualify and I can ask a question, but come on, one of you, come on. Is anybody moved by what you've heard today? Yeah, at the back of the room, please, yeah.
So Erica just touched on the...
Say where you're from, actually. Why don't we just get an idea of where people have come from? Where are you from?
I'm from Fort Worth, Texas.
Okay, great, thank you.
Fort Worth, Texas. So she touched on the deal with the rural hospitals and the rurals not getting quite the care or treatment that, you know, you do when you're in a big city, something like that. And one of the things that I ran across in my diagnosis was a local pulmonologist really wasn't up to date with what's going on with the care center network and all that. So how do you approach the local pulmonologists that the most mass population are actually seeing? How do you reach out to those folks?
Yeah, I think that's a really good question because that map, you talked about rural areas.
Yeah.
It weren't all rural areas. Some of those states have big cities in them, and yet you don't get good pulmonary fibrosis care in all places, yeah? So the registry, in a sense, is reflecting the better off parts, or the better served parts of the country, yeah? Would that be true?
Well, I think your point is well taken. I think we talk a lot about rurality, but there's also certainly places within cities where, you know, patients can live in a city with a PFF expertise and they can't access it, right? And so you can see the same delays. Ultimately, what we have is a big awareness and education gap, right? Where certainly the physicians that are here know about ILD, we're thinking about ILD, it's pattern recognition, we see it all the time, and so we know the signs and symptoms. But if you're a community pulmonologist and the majority of the diseases you're seeing are asthma and COPD, right, and somebody's coming in with cough and shortness of breath, well, that is what you're attuned to, and it's harder to think about ILD. So I think one thing to be aware of is the PFF knows this. They know this, they breathe this, they're invested in the rural health outreach. They have an entire working group that is thinking about how do we push in to communities and help address this gap. The other place is to really understand, like the education piece around interstitial lung disease. We know we need to do a better job. It's not enough to train ILD experts. We're never going to be able to see all patients with ILD. Majority of patients are being seen by general practitioners, general pulmonologists. You're lucky if you get to an expert care center, right? And so we have to provide our care partners with illness scripts so they can understand what to be looking for and they're aware of this. And then there's another piece where I really do think that AI and machine learning is going to be helpful here. And that is because we recognize that even in an expert care center, where we know a lot about ILD, not all patients with ILD are seen by an ILD specialist, and their care looks really different. And so how can we help health systems identify patients who might be at risk, identify patients who are having symptoms that are suggestive of interstitial lung disease, and prompt clinicians to say, maybe you want to think about this, maybe you want to work it up.
Yeah, very, very important point, yeah. Any other, yes. Yeah.
Just as a comment, it's not just medical professionals who aren't educated. It's us, patients, because when I started having symptoms, I thought it was just too hot outside and I couldn't breathe because it was 100 degrees. I thought it was normal aging, perhaps. And then I have my brother-in-law, who after 2 years of me having it, calls me up and says he has it. And he'd had it for probably years. Again, he said, I just thought I was getting old. I was just normally, this is what getting old is. That's the first thing patients, most of the people that have this are old. And we think we're just getting old until you're in the ER or some catastrophic thing happens and makes you face the fact there's something else wrong. And so I think we have to be a broader education to tell people if you're shortness of breath is a problem or you're fatigued all the time, go see a doctor.
Yeah, I think that's very good advice. If you get a cough that doesn't go away for a few weeks, seek help. Yeah, and it's I don't know whether it's the same in the States, but in Europe, well, in the UK at least, men don't go as easily as women. You know, we tend to hide it and pretend we're not ill. You know, sorry, please.
Yes, my question is, I'm a caregiver for my daughter, and Dr. Collins had mentioned about nutrition and eatery. Is there anything that you can do to help when they don't have no appetite? I mean, you know, so what can you do to do this? I mean, she can eat a yogurt and then she's full, or she doesn't want anything. So, you know, is there anything that you can do for nutrition? Like, it's just a little bit of stuff so then you can get the nutrition in them?
Great question.
Yeah.
I think you already kind of know, you told me the answer, which is eating kind of smaller, more frequent meals, because sometimes with lung disease, when you eat, it kind of puts pressure up on your lungs and it can feel harder to breathe. So, yeah.
Yeah.
Well, I mean, there's also so many factors that can go into this, right? Like what other medications are you on? What else is going on? And so I think talking to your pulmonologist the next time you go, but this is going on, and then they can say, well, hey, you're on this medication that we know makes you nauseous. Maybe we should think about changing that around. Because everybody's body feels things differently, right? Like you might have chest pain, but I think I have chest pressure and you have chest tightness. And so I think talking to your doc about kind of what's going on is most helpful.
Great. Thank you. Yeah. Please.
Hi. My question is for Dr. Collins or Dr. Hyland, whichever one would like to address it. I was diagnosed with IPF about 6 years ago, and my wife and I, we do not have any children, but we have been trying to follow many of the suggestions, some excellent new points that I gathered from this presentation. But the one conversation that we are unable to have is sort of an end-of-life planning. We have a familial form of IPF, so we lost several siblings to this disease already. Okay. And my wife has been involved in their end of life actively, but she refuses to come to grips with my eventuality. And just I'm unable to have a conversation. She keeps putting it off. Do you have any thoughts or suggestions on that?
I think you would be the best person.
Kathy, would you like to take that one? Or?
Sure. I'll take a stab at this. So I worked with a very wise physician many years ago who he said, why are we afraid of death when the attorneys have been doing this for years? And so the attorneys, you go see an attorney and you get your will done. And now, it used to be just wills, now you can have your power of, POAs, your advance directives, medical, who's going to make decisions for you when you no longer do. A route with your wife is maybe you go, if you haven't done this already, and make an appointment with an attorney and to do the objective documents, and that might start the conversation. That's just one idea. I'm sure other people, you're not the first person saying this. It's that denial.
Yeah. Kristen, do you want to comment on that, or on advice on end-of-life planning and discussions? Because it's such an
You know, I
important.
think there's a wonderful resource called Conversation Project, which you can Google that, and it's a workbook, because addressing the elephant in the room is really hard, and doctors are not good at it either. And you need to be empowered to have those conversations, and you have the right to have those conversations. And your caregiver needs you to have those conversations, because there have been studies that, you know, people have been married forever, and you ask the caregiver what, you know, the person would want, and they get it wrong 50% of the time. And there's a lot of, you know, there's a lot of emotion, and, you know, I almost think it's, you know, there's a lot of emotional burden to a caregiver having to guess what your wishes might be. And so the Conversation Project is like a workbook that helps you frame your thoughts around it for yourself if you're the patient, and then guides you on how to have these conversations with your family and your physician. And, you know, it's just important that, you know, the people around you are able to meet you where you are and respect what your thoughts are around this topic. And then once you address the elephant in the room, it can really take down the temperature tremendously. I think doctors, you know, they're trying to talk, they're trying to feed into your hope, and they're like, let's go take this super expensive medicine that's probably going to give you diarrhea, and let's talk about dying. You know, it's like hard to have both those conversations at the same time. So, and frankly, we don't learn how to do it well in medical school. You know, we learn from our mentors, and so we need to have those conversations better. And we need to empower our patients to be able to have those conversations. And I think it takes a lot of, you know, it's not a 5-minute conversation. And so there needs to be some self-reflection on behalf of the patient and their friends and family on what this looks like. Because it is different at different times and different, you know,
Absolutely, yeah. I know in the support
journey.
Yeah, sorry, the support group I'm a member of, we were scared ever to ask those kind of questions. And then one day somebody said, no, let's ask it. Let's get somebody in from a hospice to talk to us about planning end of life, you know, the choices at home, in hospital, you know, just practical things that help you get it clear in your mind that's what you want and the family can go with you. The whole room exploded in conversation. Everybody had been wanting to talk about it, and it was just us being frightened about raising it, you know. So thank you for that. It's a very important question.
One thing I would add that I've done with some patients is they've kind of given me a heads up that it's something they want to talk about with their family member, and then they bring the family member to the next appointment, and we can kind of start the conversation, and your doctor's there to answer any medical questions, and then I think it's easier for the conversation to finish at home. And I'm more than happy to do that for folks, and so that might just be a starting point as well.
Great. Thank you, Bridget. Thanks. One more question here.
Hi.
Sharon from Canada. Hi,
Yes.
welcome.
Hello. I just want to say that someone had mentioned that they felt that this disease was a senior's disease, and I wanted to be respectful and disagree with that, because in Canada, we're getting younger and younger individuals.
Yeah, that's true.
We have people who vaped and now have pulmonary fibrosis. We had people who had the original COVID like 5 years ago, and their lungs are fibrosing. We have people who've had connective tissue disease, and because their rheumatologist treated them with a drug that was not lung friendly, that has caused the pulmonary fibrosis as well. So I just want to say that this is not a senior's disease anymore. It's getting younger and younger. Our youngest one, she's only 32, and she's going to get a lung transplant because she wants to live and she wants to have children, but who knows if that's possible. And the other issue I want to talk about too is that we always thought that this was more of a white senior elderly male disease, but it isn't. There's more women and there's a lot of diversity. because in Canada, we have a large segment that we're trying to reach in the South Asian community, and they don't talk about it because we had one patient who said, I was having difficulty breathing. My doctor said, oh, it's your diet. You know, get on a diet, go exercise. And that's what he did until he collapsed. And then he went to the hospital, and they looked at him, they said, oh, there's something wrong. And it was very fortunate that we had one of our ILD fellows that graduated from our program that actually saw him and said, you know, I hate to tell you this, but this is a disease you have. And again, it's the biases in the medical system, right? They saw his South Asian because of his diet, because he was heavy. That's why he couldn't breathe. And until he just literally collapsed. So I just want to bring that up. And I guess, too, for the diet stuff, we talk about the North American diet, but can we talk about some other diets as well? Because we don't all eat pasta. We don't all eat, you know, guacamoles and things like that. Like, I'm just saying that we have to be respectful and think about the fact that people eat different diets.
Thanks, Sharon. We're getting quite close to the end. Let's take a couple more questions and then ask each of the panel to respond to anything they'd like to respond to. So hold it if you would, Kathleen.
No, I was going to say, can I ask a question?
Well, let's a question from the panel. Okay.
So we're in a different vantage point sitting here looking at you. And what I personally see is I see maybe some fear on your faces. So could you do could you raise your hands if this whole conversation, this session is scary?
We get a mic over here? Sorry. I'm sure you can, but it's easy with a mic.
Thank you. I was just going to say that in the beginning it was. I got diagnosed in 2019, and it was very scary. So if I just came into this, I would have been terrified. If I did not have my family as support, I would have been terrified. But my mother actually has, by the way, I'm the one that doesn't eat, Dr. Collins. But I promise I want to, but my mother actually started talking about doing, you know, or my obituary, just different things that she wanted to do for herself. So because I have them who, my father not so much, but most of us are comfortable of talking about me not being here, it's easier. But I would say if you would have caught me a couple years ago, my level would have been 100 on the scariness of this conversation.
Great. Please.
Hi, I'm also a patient, and I know my friends from the Young and Wild group. And I will say that we, as young women who have ILD, have found support in each other. So the therapy, the group talk, I found that I did not fit in a lot of groups. And even afterwards, I would get emails of, we don't think this is for you. And I hadn't said anything. They just said, we're not the right demographic. And I said, thank you for recognizing that. And then to the point of future planning, I looked at that as a gift I could give my children and to my spouse and clarity. And it was hard. And asking people, will you be my medical power of attorney if my husband cannot? But it was empowering at the same time, so.
Yeah, we actually have a young person, people still employed support group in the UK, which we do on Zoom, because your needs and your requirements are so different to people of my generation.
And WILD is on Zoom as well, the Women in ILD support group.
Oh, that's a good
also
group,
on
but we
Zoom.
also do transplants, yeah. Thank you for that one.
You know, I would really like to put a plug in for palliative care. And a lot of times when people hear the words palliative care, they get confused that we're talking hospice. That is not palliative care, completely separate things. Our palliative care people at the Cleveland Clinic call themselves quality of life doctors. That is their goal. Their goal is to make your life as good as possible for as long as God is going to give you. and to address your symptoms. While your doctors are, trying to fix your ILD, they're trying to figure out how to help you with your cough or your pain or your anxiety or your diarrhea or whatever you're suffering from. However, palliative care people are often very intimately connected with hospice and the concepts of death and dying and what that process looks like. And they are trained on how to navigate that conversation and how to meet you where you are and how to help you think about your bucket list. And it's never too early to meet a palliative care person. It doesn't make you get worse any quicker. It just might help improve your quality of life and help give you some tools on how to think about this for yourself and to how to have those conversations that are difficult to have because they're trained to do that. So just a plug, I've never met a bad palliative care person. They are fantastic.
Thank you very much, Christine. Good advice. One last question over here, and then we'll pass to the panel for their final thoughts.
It's actually a little more of wrapping some of this up in a little bow. Palliative care is covered by Medicare, and there's a lot of misconceptions that it is not. But when you dig deeper, if you call the number, if you Google it on the website, it tends to look like they don't cover it. But each and every doctor, each and every healthcare provider that you come in contact provides some sort of palliative care by definition. So that's just a quick reminder. There's another tool called 5 Wishes that help guide the conversation. The Conversation Project is really good, but 5 Wishes as well. And sometimes we just have to pause and say to my wife, my husband, whoever it is that doesn't want to listen, I need this for me to make me feel better, like I'm planning for you. And sometimes when it comes from us personally, that makes a big difference, and they start listening a little differently. And I think back to my friend Alvaret, who was part of my pulmonary rehab group, and he's like, I've got my playlist, because we also had an in-person group when we had a social worker come in, and the ILD doctors, the transplant doctors, they have a whole other support group of social workers too that can maybe help that conversation. They might have other tools. But thank you, because I've learned so much from you all.
Great. Thank you very much for that. Very nice closing thoughts.